Okay. How do we do this?
Let me see if I can do it.
Can you do it?
I don't know.
Can you hear me now?
Oh,
yeah,
yeah.
here we go. You're
Okay,
on.
perfect.
Hold on. Okay, thank you very much. Thanks, Anne. Away you go.
Good evening from Hamburg. I want to tell you something about the Aperts syndrome and how we treat it in Hamburg. I've got no disclosures. Short reminder what the Aperts syndrome is. It's the acrocephalosyndactyly, combination of bicoronal craniosynostosis, midfacial hypoplasia, and complex syndactylies of hands and feet due to a mutation of fibroblast growth factors, receptor type 2 gene on chromosome 10. It was first described by Eugene Aperts in 1906. It has an autosomal dominant inheritance. It is usually due to a de novo mutation, and it's said to occur more often in elderly fathers. How does the clinical appearance look like? We see the hands with complex syndactylies. We see the feet with the same problems. We see abnormalities of the face. Other joints may be affected, like unstable shoulders, and the elbows may have less movement. The typical hand anatomy would have 5 fingers. There's often a hidden double thumb with a broad distal phalanx and a radial clinodactyly of the thumb. Syndactylies of all web spaces from partial to complex, synphalangism of the central 3 rays. There's no movement of interphalangeal joints except of the 5th finger, and often a synostosis of the 4th and 5th metacarpal. There may be synostosis of carpus as well, mostly between capitate and hamate. It was classified by Blaut. Blaut 1 is a spade hand where the fingers lay beside each other. Blaut 2 is more cupped or spoon hand where the fingers lie a little bit curved to each other. And Blaut 3 is the more severe abnormality with a rosebud hand. So how can we improve life quality for these kids? Our aim is to have the best hand function with a satisfying cosmesis. We want a broad first web, we want separated stable fingers, and we want a straight thumb. Our treatment in the rosebud would be, first of all, create a first web. How do we do this? We do it with the dorsal rotation advancement flap, with the intermetacarpal release on both hands. And if necessary, we would resect the second ray, use full skin grafts. And with this surgery, we would try to paralyze the 2nd to 5th finger. I will show you a few slices later on. This is how it can look on the Aperts hand. And if we have release the first web, we would treat the kids afterwards with splints to hold the result. Our second step would be the syndactyly release of the 4th and 5th fingers on both hands again. So how do we do our syndactyly release? We do it with the approach modified by Cronin, with a proximal triangular flap and a zigzag incision towards the fingertips. How do we do it on Aperts with the missing interphalangeal movement? We do the same proximal triangular flap, but we would do a straight incision towards the fingertips. Afterwards, we would do the palplasties as Grumko taught us, and would do the same proximal triangular flap and incision towards the fingers on the palmar side. With the first or second step, or better said, with the first operation, we would do a paralyzation, an alignment of the fingers, as Upton talked about a few years before. We would separate the nail band, we would separate the synostosis of the distal phalanx, and we would align the fingers and put a K-wire 0.8 through the distal phalanges. We would leave the K-wire for 4 weeks. As long as the kids have the K-wire, they will have a plaster of Paris as well. And afterwards, we will take it out, and this facilitates along the next step. The next step would be the separation of the syndactyly of the 2nd and 3rd finger, again on both hands, in the way I've already shown you. We like to combine it, if possible, with the 2nd and 4th web space. Our fourth step is to separate the third and the fourth finger. The problem is they are synostotic fused, and because you have already used PULM plastics for 4 and 5 and 2 and 3, there's only little tissue left for new plastics. So therefore, our former head of department, Dr. Habenich, developed this cube fix, the mini fixation system a couple of years ago. How do we use it? We separate the nail band only on one hand this time between the third and fourth finger. We would separate the synostosis in between those both fingers. They have to be movable. And if they're movable, we can start with the first K wire. It's a 2.0 K wire with the middle thread. And we would put it in the proximal part of the proximal phalanx. And we would do this on the third and on the fourth finger. And then we would do a 1.0 K wire on the distal part of the distal phalanx. This K wire has to go distally to the lunula so that we don't disturb the growth plate. Then we would put on the cubes, and we would add a 1.0 K wire on the distal part of the proximal phalanx and a 0.8 K wire on the distal part of the distal phalanx, and then add the cubes. In the end, we would have 4 distraction places, 2 on the dorsal and 2 on the palmar. We teach parents how to distract and do the soft tissue distraction. And they distract every day, one turn of the distractor on every part of the fixation system. So on 4 places, 2 dorsal and 2 palmar. And every turn of the distractor is 0.5 millimeters. We want them to reach 20 millimeters so that afterwards we would have enough tissue. They would stop then for 2 to 3 weeks to let the hand rest a little bit before we can then separate the fingers. With the same surgery, we would straighten off the thumb. This is what we want to get. We do it again with a rotational flap. We divide the extensor tendon. We do a curved osteotomy. We align the bones to each other. This is on the proximal phalanx. Then we put a 1.0 K wire in it, and we would secure it with a 4.0 cerclage against rotation. So with this technique, we have a straight thumb. This is the X-ray. Usually we do the transfixation of the MCP because the proximal phalanx is that small that it won't heal and stay in the place you want the K wire, so we transfix it for 6 weeks. In the 5th step, we would remove our fixation system on the first hand and do the syndactyly release. And on the same anesthesia, a second team would build on the fixateur and straighten up the thumb on the second hand. This is how it looks. After 4 to 6 weeks of distraction and 2 to 3 weeks of rest, we take out the fixation system and do our approach with the straight approach. The sixth step would be the same on the second hand. We would remove the fixation system and release the syndactyly. These are some results. Of course, we do not get normal fingers, but the kids get quite well along. After separation of the fingers, we would just let the kid grow and rest from the surgeries, because after all, they are not only the surgeries of the hand they have to go through. If further on we see problems with the ulnar deviation of the 5th finger due to the synostosis of the 4th and 5th metacarpal, we want to straighten up the 5th finger, and we do this on with two different techniques, and we do it whether by callus distraction or by dome osteotomy. Our first option is the transverse callus distraction. Therefore, we use the cube fixation system again, and we would do the callus distraction till the 5th finger is aligned to the 4th finger, and then we would let it heal in the fixation system. So this is before, and this is with still the fixateur on after the callus distraction. The second option would be a dome osteotomy and plating. So we can do everything in one step and let it heal under the plate. This was the same patient. We used 2 methods and both worked. She gets well along with it. What else do we see? We see a lot of nail bed infection due to the curved position of the fingers and the pulp going over the nails. Of course, you have to address this. But since we do the alignment of the fingers or the paralyzation, we have seen much less complication with the nail bed infections. What else? The release is not always possible or helpful. Every therapy has to be individualized. If you see this patient, we separated first the first web, then the 4th and 5th, then the 2nd and 3rd. And there's no chance to separate the 3rd and 4th fingers because there's not only the synostosis of the distal phalanx, but a complex synostosis of the proximal phalanx as well. So in this case, we would just straighten up the 3rd and 4th ray. What about the feet? Feet have similar problems with Aperts. There's no interphalangeal movement. There's a hidden double big toe. There's a very short first ray, and the weight-bearing movement goes over the 2nd toe. And we see very wide feet and problems with shoes. But after all, feet have other aims than hands. And we believe you have to address what disturbs. I brought you one example. You see the very bright foot on the right side. This was disturbing in the shoe. This is the X-ray. You see the hidden first ray. So we took away what was disturbing. We got a much smaller foot. And now she's able to have one side of foot, one size of shoe to fit on both feet. The conclusion, the most important and first to address is the first web space. We do this in the age of 6 months. Our second step would be the release of the syndactyly of the 4th and 5th finger. The paralyzation facilitates the next steps. The third step would be to build up the second web space. The 4th to 6th step is the release of the syndactyly between 3 and 4 with the external fixation system. In total, 3 surgeries plus the positioning of the thumb in upright position on the first and on the second hand, and later we address whatever causes problems, for example, the synostosis of the 4th and 5th metacarpal. Every patient is unique, and parents need a lot of support, information, education about the syndrome and about the outcome. In Germany, there's a very good organized parent organized self-help Apert group, and we always recommend this to the families. This is our team. Thank you very much for your attention.
Thank you, Anne. That's fantastic. The results. This is anyone who's treating these kids. It's a very challenging problem with a lot of surgery involved. Big investment for every child. So just in terms of there are a couple of questions on the chat line. The Cube Fix distractor, is that commercially available or is that?
Yes, it was developed by Litos, but Litos no longer exists. And now it's from Innovation Medical. They are in Tuttlingen in Germany, and they are still providing it.
And the Cronin incisions, the zigzag incisions you're only using those in the 4th web?
Yes.
Because it's the 5th finger is mobile and you don't want that.
If we have a movement, if we have a good movement, we use the zigzag incision. If we have no interphalangeal movement, we change to the straight incision because it's much easier, it's faster, and you have afterwards one big part of the finger where you need a graft, and so you have one big graft per finger and not as in the usual syndactylies like 3 per finger. So the surgery needs just less time and it works quite well.
The other thing is your approach to the 4th and 5th synostosis is one of osteotomy or distraction. The alternative is to try and release the synostosis and try and maintain some mobility, but the issue is obviously is refusion. Is that why your center does a bony procedure because of that, trying to release the synostosis is just too unreliable?
Yes, it is. It just doesn't work in the long term if you just would lose the synostosis and it gets bony again and the finger would stay again in ulnar deviation. And we just saw that we have better outcomes if we distract it and put it in the way we want, that we have a aligned fifth finger.
And so there's some other questions here. So one question is, there are published series of single stage releases of all digits, which, you know, obviously is got to have some risk. Have you got any comment about, you know, the issue obviously is with these children is with all their craniofacial surgery, they're in and out of the operating theatre, they're getting upper respiratory tract infections every 5 minutes, and it turns into a well-defined surgical schedule turns into a saga. Have your team ever thought about trying to shorten that by doing more than one web at a time?
We do combine the third and the fourth web space because we don't have the fingers beside each other, but we do not believe it helps the kids if we do too much on the hand, because on the small kids, the hands, they will swell always quite a lot, and the Apert kids, they seem to bleed a little bit more, so you have diffuse bleeding, and we really are a little afraid of losing fingers, and they have bad fingers and they have a lot of issues, so we don't want him to lose a finger after all. It's just not the philosophy of our department. We want good and safe results.
Absolutely. My experience is that often they've got the distal vascular or distal digital artery bifurcation. The vascular anatomy is not. And so are you just cutting and dividing one of those vessels? And
yes, we check it. We check it if we can do it or not, whether we can do it or not. We loose up the tourniquet and see which finger would like it better to be without the second vessel, and then we would give the other finger the vessel. If no finger would be able to accept it, we would just separate as far as the bifurcation goes. But in the Apert, we do not have that much problems with this. Usually it's possible. And with the distraction on the third and fourth finger, there's a neovascularization, and even if you have no vessels that you can see, we have never had problems with the blood supply of the fingers. So it seems that the distraction causes such a good neovascularization that we can still separate the fingers, and even in the long term, we don't see brighter problems.
that's great. So just in terms of remaining questions here, and how many? I think that's really a question about the number of procedures. But one last question is in the amputation. It's always and I don't know whether Dan or Zesko have got a comment about this. I see that your colleague Webker is in the audience. The debate about the 3-fingered hand and the 4-fingered hand for these children is always, because there's always a shortage of skin. There's never enough skin.
Yes, there's never enough skin, and we do discuss it with the parents if the first web is very narrow, that we have to reject the second ray for a good first web space. And we believe we help the kids with it. So this is something we do because we really believe we can give them function. And discussing this with the parents, they will understand, because they see that their finger are very bad movable. So this is something they understand. Everything else you have to discuss with them. We would not just take a finger away because of too less skin. And with the possibility of the distraction, we gain a lot of tissue. We even can discuss if there's too less tissue to do this distraction on other fingers as well. And we don't only use this for a Apert, but we use it for complex syndactylies as well. So there is, with the distraction system, we gained a method that we can separate and treat syndactyles that we wouldn't be able to do without it. So of course, it's a lot of surgery, it's a lot of problems for the parents. They have to do this by themselves. First, they are afraid, but it really works quite well, and the results are really good. And usually parents want 5 fingers. And of course, we know there's no better function from the 5 to the 4th fingers. If we wouldn't separate 3rd and 4th in the Apert, we wouldn't have really a difference of the function. But for the families, it's very important. And this is a very good method to do so.
Yeah, I appreciate that. Just one quick question. In terms of graft donor site in these children, it's always a challenge because they're limited.
Yeah.
Often they need a lot of graft, and you can't go, and it's bilateral, so you're really running out. What's your preference for graft donor site?
We go to the lower abdomen. We do not go to the groin anymore because with the pubic hair, it doesn't look very nice. And we need a lot of skin. So elbow or wrist is just not enough. So we take the lower abdomen. And the kids usually, yes, they're in the bikini zone, and there where the belly goes over, like there we have quite a lot of tissue, and the kids in this age, they're quite elastic. So even if we need quite a lot of grafts, we still can close the donor site quite well.
So Jessica or Dan, have you got any comments, questions for Anne? It's a tough challenge, these kids. It's super satisfying, but it's a tough challenge.
So just one question. The cube fix is indicated in rigid digits, right?
Yes.
Even if it's Aperts syndrome or another kind of syndactyly, only for rigid digits, right?
Yes. No, well, we use it a little bit different in complex syndactyles, for example, in the 4th and 5th fingers, if they have a different length and are very narrow, and you have no good pulps because they are so close together. We do use the fixation system as well, but we would align the distal interphalangeal joint with an extra K wire, like an axial one, from the tip of the finger into the distal and middle phalanx in the normal finger. And then if we separate, we do not stress the distal interphalangeal joint. This works good as well, yeah. But of course, theoretically, you have the problem going through the flexor tendon. But after all, we do see good results with this, and it does work.
Interesting. It might be one more it could be another topic in another PULM session in techniques. The use
would be great.
Would be nice. And thank you very much.
I've got, if you want to see, I didn't put it in you only gave me 13 minutes, that's just not too much. But I do have slides if you want to see it, where I could show you how it looks on other syndactyles. Just let me share my screen again. This is how it could look in other syndactyles. And this is a complex as well with this diamond shaped. But as I said, we use it in very bad pulp conditions of the 4th and 5th fingers as well. And we there you can see that we have an axial K wire going from here. It looks a little bit different from what I showed you before.
Wow, that's a pretty amazing result. That's incredible. Dan, have you got any comment, or Webke Hulseman works with Anne, have you, who's on the call?
Yeah, she's my boss.
Yeah. Dan, have you got any comment?
Oh, just pretty spectacular. I'm very jealous of your results. I think aesthetically, though, I mean, that's tremendous. You know, my only question is functionally. I mean, I've been reluctant to separate those 2 central digits because of, and I'm not sure that, I don't know. Have you seen a functional improvement? There's certainly an aesthetic improvement.
Yes. With the 3rd and 4th fingers, it is only a cosmetical bettering of the hand, not a functional better outcome. But as I said before, the kids, they do not look normal, not from the face, not from the feet, not from the hands. And if they have at least 5 fingers, they feel much more comfortable.
Yeah, you know, that's it's something that Roger Cornwall termed, what did he call it, David? Social function.
Yeah, it is.
You know, it's not just function in terms of how you move your fingers, but there's also social function, and that's not to be discounted. So kudos to you on some great results.
Thanks.
Kara, you're unmuted there. Have you got anything to add to this? Because it is. I think this is we tried to get one of the cube fixes in, but it was unfortunately pretty expensive. But I think it's a great technique where you're so short of skin and everything's so tight.
Would be a very good idea to look for the technique in different complex surgeries in the future. We found these cube fix very helpful because it's one of the very few methods to get more skin, to get solutions for syndactic releases, which otherwise we couldn't do. And yes, it's expensive, but it depends on the conditions you work in your countries, because it's like an old Mercedes. You can use the outer parts again and again, and they will run. You have only to change these KYs, and they cost little. But that's different from one country to the other. If you would have to throw it away, the whole system, then it's very, very precious.
I think in Australia it's a single use. That's what we were told.
Really?
Yeah.
It does not make sense, not because the outer.
No, it's crazy.
Yeah.
Completely agree.
Yeah.
So thank you very much. That was a great talk, and we're really nice to see you, Kara. Great to have you on board.
Thanks to open my voice. Good luck.
Bye-bye. So the last talk we've got today is from Francisco Soldado, our leader